Look, guys, in the interest of time, I want just 3 or 4 rapid-fire questions. There's a lot of questions from the audience. If I can ask Osman, Professor Osman first. In primary care, we're often, some of us are reliant on the ECG interpretation of the machine interpretation. How far are we from being able to totally rely on that, particularly with artificial intelligence and machine learning technology? Or do we still need a clinician to confirm the trace is atrial fibrillation?
Thank you for that. Yes, that's a very good question. So I think the NICE approval that AliveCor got actually included its algorithm as well of AF, no AF, or indeterminate. So I think technologies can help, and they clearly have programs that are going to help us, and we are going to need help, because if we are going to go out and start screening people, we're going to be seeing a lot of people with a lot of traces. A lot of them understandably will be worried, and so we need to be able to answer the question. It will require a lot of resource. So these algorithms, I think, are helpful, are useful. A lot of the interpretation depends on the quality of the tracing, and I think it's important we let our patients and the general public know that the quality of the tracing matters. And I think we're getting there, but we're not quite there yet. I think very often there is interpretation that's needed, and very often a cardiologist may even need to look at it. Sometimes it can be very difficult, even for us, to know actually what is this atrial fibrillation or not. So I think the technology is moving, and you touched on AI, and artificial intelligence undoubtedly will help. And I know these companies and many other companies around the world are investing heavily in AI, and undoubtedly it will make a difference. But we will need that AI help, because of the sheer volume of traces that we will have to look at. So I think we're getting there. We're not quite there. And I think we still need the human eyes often to have a look at the traces that are sent to us.
So the machines are getting better, but they're not quite at the level of a cardiologist to review that ECG. Another question, please, for Barry. You mentioned this sort of interlink between blood pressure and AF. Just very succinctly explain to us why it's such a particularly bad combination for AF-related strokes, Barry.
I think it's really important to highlight that when you have a hemodynamic insult like your AF that you're potentially persistently in, that you have it increases your hypercoagulability and your chance of having a thromboembolic event. But that thrombus, or the clot that's formed in a higher pressure system like high blood pressure, will increase its formability, but also increase its risk of getting transmitted to the brain. If it's inside and it's aligned to the inside of the arterial wall, then a higher turbulence, higher pressure will drive this increased risk of it being dislodged from the inside of the carotid, for example, and then that gets transmitted to the brain. So this interconnection between high blood pressure, increased turbulence, and the clot itself is a really bad combination that presents to the ischemic stroke that will be the result for that individual.
Great, thanks, Barry, for that. And Prof, again, a question to you. We've had unprecedented times in the last couple of years. Lockdown has impacted on a lot of people's lifestyles. Dare I say it, alcohol intake in some patients has been more excessive than usual, shall we say. How common is alcohol-induced AF, and how much should we be hunting for or taking a very detailed alcohol history in some of these younger patients with AF? How common is that as a cause for AF?
Again, a very, very good question. Alcohol is, without doubt, can be a very important factor and a trigger in people who present with atrial fibrillation. And certainly the patients that I tend to see in my EP clinics, they're referred for consideration of an AF ablation. I try and spend a little bit of time with them. Obviously, we have limited time, but it's very important to highlight to patients that actually these risk factors, particularly alcohol and smoking, are things that the patients can do something about. And you're quite right, COVID has been difficult and has impacted the intake of alcohol. But it's very, very important that people who have atrial fibrillation, particularly those who are on therapies, antiarrhythmic drugs, or who've been considered for an ablation therapy, to recognize that actually it's very important that these adjustable, modifiable risk factors are tackled. And we here in Coventry are currently planning on doing a study looking at patient education and risk factor modification prior to AF ablation and after AF ablation, and hopefully we'll get some idea from that. But there is evidence, quite strong evidence now, that alcohol intake, in terms of controlling it, reducing it, is important in terms of outcomes of atrial fibrillation, particularly with regard to AF ablation, for example.
Oh, that's a really good point. And similarly, I guess weight loss is also a really important determinant of successful ablation outcomes. Right, very last question. We often get mixed messaging about intense physical exercise and its impact on atrial fibrillation. Just very quickly, any member of the panel can chip in here. Good or bad for AF? Because we know that extreme exercise can often induce sort of paroxysmal AF, but in general, what's your take on patients who are wanting to do intense physical exercise with atrial fibrillation?
So again, another very good question. If I just answer, and I'll hand over to my panel members. In terms of the study we're planning here, we're looking at not only risk factor modification, but gentle exercise over a period of time. Because you're quite right, exercise is important. There is evidence that actually gentle exercise is good for you. Doing a steady workout for longer can be a very useful thing. And again, relating to weight and weight gain and weight loss, the more activity, the more physically active you are, hopefully that will lead to a better body mass index. And we know that the higher your body mass index, the worse your outcome when it comes to AF. In terms of high intensity versus moderate or low intensity, again, there is debate raging about the benefits and risks of either. I tend to advise patients to do moderate levels of exercise. Patients know how far they can go and what they can do. And I always say to them, actually, walking is often a very gentle form of exercise that you can do for a lot longer. So, I would certainly advocate moderate levels of exercise.
Barry or Lucy, anything to add?
I would echo that in terms of the moderation of exercise. But we also know that exercise itself increases and lowers blood pressure in addition to the risk for AF. So like Professor Osman mentioned about weight loss, but it improves the vasculature, improves everything that we need from a hemodynamic perspective. So again, I'd be a big advocate of the improving physical activity within moderation.
It's really the extreme endurance athletes. Really, they're the ones that, Prof, you do see from time to time developing atrial fibrillation from that extreme endurance. But they're likely to be CHADS VASC 0 and be at low stroke risk.
Yeah, no, you're absolutely right. I do see, we of course know about athletes' heart and people who do a lot of triathlons or marathons, and I see those patients in my clinic, and they come in, they're young, and all of a sudden they've had atrial fibrillation, and you do an echo, and they've got some changes, the LV's a little bit dilated, there's a bit of hypertrophy, and I think in the old days we sort of kind of dismissed it, but I think there's an increasing realization that athlete's heart is not quite as benign as we thought, and certainly patients who do a lot of this high-end training, very, very intense for long periods of time, putting a lot of stress on the heart, it may not quite be as benign as we thought. And actually, we certainly know that it's linked to atrial fibrillation.
Great. Thank you very much, guys. You've been, each of you have been a superstar today. Sadly, we've run out of time, but what a wonderful trio of presentations by our expert faculty. Let's now revisit our original case that I presented right at the beginning, this tragic young female patient who had every right to expect many good quality of life years ahead in the early stages of her retirement, tragically suffering an AF stroke, and now destined to spend her last few weeks or possibly months lying in a nursing home, not being able to speak, swallow, or move half her body, the worst possible outcome you can imagine for a patient. And tragically, this is an all too common scenario. We know that AF is responsible for around a third of all strokes, but 50% of AF strokes occur in patients previously undiagnosed. In other words, as the first presentation of atrial fibrillation, stroke is really winning the race far too often. And we know that hypertension is a key risk factor. Barry has eloquently described how not only does it develop or assist the development of atrial fibrillation, but also independently increases the risk of stroke. I think having a portable ECG monitor integrated with a blood pressure machine is a wonderful marriage of technologies, a great innovation that can help address the huge burden of avoidable catastrophic stroke. I'm certainly going to be getting one as soon as I possibly can and deploying them in my clinical practice. And often premature stroke, is what happens in these patients. It's the premature nature of the stroke that is equally devastating, and it comes at huge costs, not just to the NHS, but of course social care and massive human costs. So I think by embracing this type of innovation, by being proactive, using technology like Omron Complete and deploying its use appropriately, we have a wonderful opportunity to add a huge number of years to life, as well as a massive amount of life to those years, by detecting more AF opportunistically as really part of routine clinical practice. I'd like to thank Omron for kindly sponsoring this webinar, Radcliffe Cardiology for hosting it, our tremendous expert faculty for their great insights, but most of all you, the audience, for your very kind attention and interaction. Goodbye and have a lovely evening.